So we started our lesson on heat injuries by looking at heat exhaustion. Let's look at what happens when the heat exhaustion gets out of control. So normal body measures for managing high heat are vasodilation, decreased activity levels, and sweating. And these typically do a good job at managing our core body temperature. But when these mechanisms start to fail, or when they can't keep up with the environment we're in, we can be in trouble. Heat stroke is hyperthermia accompanied by a systemic inflammatory response causing multiple organ dysfunction and often death. Some key diagnostic factors for heat stroke are a temperature greater than 40 Celsius, signs of organ dysfunction, which can be altered lab values, acidosis, altered mental status, and an inability to thermoregulate. Let's break these down a little bit. Once our body gets above 40 Celsius, a bunch of bad things start to happen to our cells. Plasma membranes become damaged, ion pumps and transport mechanisms begin to fail, and the cells have a decreased ability to repolarize. The most temperature-sensitive side effect is that at temperatures greater than 40 degrees Celsius, proteins begin to denaturate or become deformed. These deformed proteins often interfere with other processes in our body, which can start a cascade of effects. For example, the blood clotting cascade can be severely affected by temperature, and heat stroke patients are often found in DIC. Some of these deformities can be resolved if we can get the patient back to a normal temperature. Organ dysfunction is a big finding of heat stroke. As our bodies get warmer, blood is deferred away from the core and pushed towards the peripheries in order to help cooling. This decreases the perfusion to vital organs like the kidneys, brain, and GI organs. As such, these organs can become hyperperfused and eventually ischemic. Common signs of this will be altered LOC, seizures, hyperkalemia, increased creatinine, and decreased urine output. The most serious signs to watch for in a heat stroke patient are the CNS dysfunction, things like agitation, delirium, seizures, and coma. Lastly, in heat stroke, we have a decreased ability to thermoregulate. When a patient has heat stroke, they often become confused, and this confusion can prevent them from being able to leave the warm environment, or they'll make decisions that will worsen the condition. Seizures can cause increased heat production, further compounding the problem. Patients often lose their ability to sweat, which can affect their ability to cool themselves through evaporation. This isn't always present, especially when we look at patients who have exertional heat stroke. On that note, who gets heat stroke? Well, to answer that, we first need to look at the two types of heat stroke, classical and exertional heat stroke. Classical heat stroke is when a patient is left in a hot environment for prolonged periods of time, and their thermoregulatory methods just can't keep up. So think of a kid left in a hot car, or an old person at home in a heat wave. They can handle the high temperatures for a while, but eventually the heat gets to them, and they start having signs of organ dysfunction. These patients are often found with altered LOC, hot, dry skin, as the body loses the ability to sweat. It's really easy to confuse this type of heat stroke with other conditions, like sepsis, due to the other comorbidities. Exertional heat stroke, on the other hand, is caused when the body generates too much heat and can't cool itself. Some great examples are someone who works out in a small, poorly ventilated bedroom, or a runner on a hot, humid day. In humidity levels over 70%, sweat doesn't evaporate heat effectively, and rates of the heat stroke can skyrocket. The big difference with these patients is they are likely younger and healthier. The timeline is typically much shorter, and these patients will have wet skin due to sweat from the exertion. Treating heat stroke is all about getting the body temperature back down below 39 degrees Celsius, so the natural cooling mechanisms can kick in. Some great examples of how to cool somebody are ice baths, spraying water with a fan, ice packs to the groin and axilla, and chilled IV saline. Just be careful you don't cool them down too quickly, or you could cause the patient to start shivering. Once the patient's cooled, treatment is usually supportive, and monitoring to see the extent of the organ damage. The big decide for mortality is going to be how long they've been hot. 20% of survivors from heat stroke have found some form of permanent neurological damage, and many leave hospital with decreased renal function.